2 o'clock. Good afternoon, everybody. Thanks for coming. I'm Michael Eman, and along with Drs. Westifer and Hinson, we're going to spend the next 20 minutes or so discussing the most up-to-date evidence on the association between intravenous contrast administration and kidney injury, with a special focus on patients with baseline renal dysfunction. But first up, the three of us have no relevant disclosures. We're going to start with a real quick case that we think should look pretty familiar to just about everybody who's worked a shift in the ED in the last, say, week or two. So we've got Miss Davenport. She's a 62-year-old lady. She has a history of CKD, and she's coming in with chest pain. You're worried about PE. She's stable, but her well score puts her into the moderate risk category. She's got an elevated dimer. Her pro-BNP and her troponin are elevated. So you're thinking maybe she's got some submassive PE criteria. And her serum creatinine is 1.7, which puts her at a GFR of 37. So we're going to try a poll here. Before obtaining a CTA for Ms. Davenport, whose institution would require any of the following? The CTA could just happen. You'd have to talk to the radiologist. You'd have to talk to a nephrologist. You'd have to give her some fluids, or sorry, you can't give her contrast at all. Give you 10 seconds to click this reflexive response. All right, last couple here. So we've got a pretty good mix. It looks like there's a fairly even split between 1 and 2, and then a handful would require fluids, and then a few would not permit contrast to be given at all. So that's great to see that about half of us are operating on probably the most up-to-date evidence, but we're going to dive in to all of this with a little bit more detail for the next 20 minutes. So here are our learning objectives, which you can look over. But first, to discuss the historical literature about where contrast-induced acute kidney injury kind of came from, I'm going to hand it over to Dr. Hinson.
All right, thanks, Michael. I think when we talk about a topic like this, where we're sort of questioning a paradigm that's been held in medicine for a long time, is to start at the beginning, right? So where did this all come from? This is probably at least the most famous of the very early reports of contrast-induced nephropathy in the literature. Looking back at these articles is pretty interesting because they did things like include the name of the patient in the case report. And this was a 69-year-old guy who was a farmer, probably not this particular farmer, but he was a farmer. And he was not feeling well for a long time, went to the hospital. During the hospitalization, he had a lot of diagnostic procedures, labs sent, and they were trying to figure out what was going on. And he had a precipitous decline, developed acute renal failure, and died within a couple days. The article is actually a post-mortem analysis by a pathologist. They're taking the kidneys of the patient, they cut them open, they look at them, look under the microscope, and they then discover he has all these Bence-Jones proteins, and that he likely died of severe multiple myeloma. That's the diagnosis. That's not the title of the article. When they looked back at his clinical history, they saw that right before he developed the precipitous renal decline, he also received 20 cc's of this pretty caustic high osmolar contrast reagent called diodone for a pyelography. And they thought, well, maybe the Bence-Jones proteins were actually precipitated into the renal tubules by the contrast. And so this is the first time where we have contrast associated with renal failure, and not even really a causative study here, but an association. So that's the beginning, 1954. Over the next 5 to 6 decades, there was just an explosion of people writing about contrast and nephropathy. It's termed CIN, CIAKI, CAAKI. There's tons of different terms for it now. So usually contrast-induced nephropathy or contrast-induced acute kidney injury. So more than 3,000 articles published on this topic. More than 150 trials were done, where they were randomizing patients to experimental interventions that aim to prevent contrast-induced nephropathy. This represents millions of dollars, often federal research dollars allocated to this. thousands of patients were enrolled in these trials and received experimental therapies. And then many thousands more were treated under this paradigm of contrast-induced nephropathy, where oftentimes contrast was withheld and continues to be withheld for important diagnostic procedures out of fear for precipitation of AKI. This is probably the most widely cited article. I guarantee you it's not the most widely read article, but if you look in the literature, this is the one that everybody keeps pointing to, and you'll often see this statement: contrast-induced nephropathy is the third leading cause of hospital-acquired AKI. So where does that come from? This is a single center study of 2,216 patients. 1983, they decided to follow these patients over the course of their hospitalization and to see which ones developed AKI. And then they would just look and see what had happened to them that could have caused it. So of this over 2,000, only 129 developed renal insufficiency, now termed AKI. This is the main table from their article here, showing what they attributed the AKI to. For 16, it was contrast media. The most frequent was decreased renal perfusion and major surgery. What was required to be attributed to contrast? Just that you received contrast in the 24 hours prior to the AKI and didn't have another obvious cause of AKI. So again, this is an association, not a proof of causation. And this is a very small study. And this is just sort of like the lore of the literature where things keep getting pasted forward into new articles. Regardless, we start to have a proliferation of guidelines around all of this. So all of the professional organizations sort of threw their recommendations into the ring. We have formal recommendations on the dangers and the need to risk stratify prior to use of contrast media from our radiology organizations in the United States, Canada, and Europe. In 2012, there was a huge really great, actually, AKI guideline published by KDIGO, an international organization. An entire chapter of that is actually dedicated to contrast and AKI. And then many other specialties got involved as well. Here I'm showing cardiology, talking about the risk of contrast-induced nephropathy and what we should do to try to prevent it. This is the first guy, I think, who brought some real rationality to the situation. His name is Jeffrey Newhouse. He's a diagnostic radiologist at Columbia. In 2006, he published this sort of critical appraisal of the literature. He said, look, we're talking about performing diagnostic procedures with intravenous contrast, and there are all these guidelines about it. We're doing all of these interventions to prevent it. What does the literature actually say? So he looked and said, I see there are over 3,000 publications on contrast-induced nephropathy in the literature. How many of those actually include a patient who received IV contrast? 40 of the 3,000, right? And only 2 of those 40 included control groups. I'm not talking about a randomized control trial. I'm talking about any control group at all. And I won't tell you what those showed. We'll talk about that a little bit later, okay? He did another study, which was very interesting. So this was a retrospective cohort study in over 30,000 inpatients who had creatinine measured on 5 consecutive days. So it's just a convenient sample here that he's looking at. In these charts on the right, you can see basically where creatinine was going. In some patients it's going up, and some it's going down over the course of the hospitalization. And the first graph here is just absolute increase or decrease, and on the right it's percentile. So the major findings were that very common to have an increase. It was even more common to have a decrease, okay? And if you look at the percent of patients who are having an increase that met criteria at that time for CIN in the literature, it was like 6 to 8%. What is reported in the literature is a rate of 6 to 8%, a rate of acute kidney injury after contrast was administered using the criteria they had at that time. This is the kicker, is that none of these patients received contrast media. So Dr. Newhouse's work really opened the door for all the work that we'll sort of talk about now. So I'll hand over to Lauren.
So I know when I first looked at this, I was like, I mean, it seems simple. What if we had a comparator group for these things? I mean, it seems simple now, but as you can see, methodology has really sort of changed from when we accepted like 100-word methodology section in which patient names could be revealed to now. And so when we look at this, we have to consider, what if we had a comparator group? So not just those that got contrast-enhanced CT scans, because some people that are admitted to the hospital and have serial creatinines are going to develop an AKI. So looking forward to this, looking at just a survey of some of the literature out there, looking at a study of elderly trauma patients, so people that are often going to get IV contrast-enhanced CT scans. rate of the proportion of patients that had AKI and they got contrast, 2.2%. Those that didn't get contrast, proportion was 1.8%. Similar article, although not in trauma patients, those that got a contrast enhanced CT scan, AKI in 4.8%, no contrast, they had 5.1% got AKI. So people are getting AKI in both groups. Again, another article, this is Davenport et al. Contrast group, AKI in 8.3%, in the non-contrast enhanced CT group, 8.6%. Yet another article, those with acute stroke, often where we want to do CTAs, the proportion of those that got an AKI in the contrast enhanced CT group, 3.2%, in the non-contrast group, 5.3%. And to be fair, these are not randomized controlled trials we are looking at, but they are at least have a comparator group. This study, the next study is the risk of acute kidney injury after IV contrast media, did some propensity scoring. So they tried to find, still retrospective, still observational data, but they tried to match patients that might otherwise be somewhat similar. Again, the rates of, or the proportions of patients with contrast versus, that got contrast versus no contrast, the proportion that developed an AKI or a rise in creatinine, very similar. Another propensity match study looked at, well, okay, let's take the same population, and it might be that people are worried about, giving contrast, and so they might just not order that scan or think it's important. But looking at PE, where you could do a VQ scan, you can do a CTA. Again, the proportion of patients that developed acute kidney injury was really not that different between groups of people. And so when you look at this evidence altogether, synthesize it in a meta-analysis, looking at only those studies that have some sort of comparator group, a CT scan without contrast, so patients that are otherwise undergoing imaging, not well enough to just be discharged or something like that, and have that follow-up creatinine, the odds of an acute kidney injury is not significantly increased in the contrast group. Well, what about renal replacement therapy? I mean, a little bump in creatinine, not that big of a deal, but hemodialysis, that's something I certainly don't want. Again, no increased risk of receiving renal replacement therapy. Dying, what about mortality? Again, no difference here in that group. There wasn't an increased risk of death in those that underwent a contrast enhanced CT scan. So when I look at this data, what I take away from it is that people who are sick enough to get repeat creatinines, I'm not sure if that's really a word, but that are sick enough to get serial creatinines and imaging, they are also likely to get an acute kidney injury. And the takeaway from here is people who are sick, they may develop an acute kidney injury. And whether that is due to contrast or not, we will find out. But the current evidence up to this point, and looking at all those observational trials, really doesn't appear to be the case.
So the American College of Radiology and the National Kidney Foundation kind of tackled this question. As you're probably aware, these are the two national societies that represent their respective specialties. And they created a joint consensus statement early last year in 2020, which was published simultaneously in their two flagship journals, Radiology and Kidney Medicine. And the first thing they addressed in this consensus is the distinction between contrast-associated acute kidney injury, meaning AKI after receiving contrast from any cause whatsoever, and contrast-induced AKI, which Dr. Hinson already kind of alluded to, which is causative contrast resulting in acute kidney injury. So they reported here that using the stage 1 KDIGO criteria for AKI, the risk of contrast-associated AKI increases with each stepwise increase in CKD stage, up to a chance of about 30%, or a risk of about 30% in patients with the most impaired baseline renal function. Using those same KDIGO serum creatinine AKI criteria, the risk of contrast-induced AKI as opposed to contrast-associated AKI is substantially less. So contrast-associated AKI is shown here on this graph by the gray line, and then the contrast-induced AKI rate is shown by the blue bars. The actual risk of contrast-induced AKI remains uncertain, especially in patients with severe kidney disease, because there are no randomized trials, as we just heard from Dr. Westhofer, differentiating contrast-associated AKI from contrast-induced AKI in patients with a GFR less than 30. But there are a number of large observational retrospective studies that showed no evidence of contrast-induced AKI, regardless of CKD stage, whereas some others found the numbers shown here in blue. So what do we do with these data, right? The ACR-NKF consensus asks and answers 10 key questions in their consensus statement. And we're going to take the last couple of minutes here to review a few of them that we all thought were the most pertinent ones to us in the ED. So first, what GFR threshold, and again, these are baseline chronic kidney disease patients, what GFR threshold should be used by radiologists or radiology departments to trigger consultation between the referring clinician, us, and them on the radiology side before administering contrast? Well, they said that for patients with pre-existing AKI or AKI that's already occurred before contrast, or with a GFR less than 30, including patients who are on dialysis who are non-anuric, if they're ordered to receive contrast, you should expect a phone call from the radiologist when the GFR is below 30. For patients greater than 30, there's no reason to have a conversation. There's no reason to limit the ordering of contrast for these patients. So hopefully your phone will be ringing one less time when a patient with a GFR of 35 is ordered to get that necessary contrast-enhanced CT scan. Second, which patients should undergo prophylaxis to prevent acute kidney injury prior to contrast administration? So prophylaxis is indicated for patients who have an AKI already or who have a GFR less than 30 and are not undergoing maintenance dialysis. The consensus authors are really recognize that the evidence supporting this statement is based on data for the general prevention of contrast-associated AKI rather than contrast-induced AKI per se. And they also state that the risk of prophylaxis for patients with heart failure or other hypervolemic conditions should really be considered before you're giving crystalloid as prophylaxis. But certainly they say that prophylaxis is not indicated for the general population of patients with a stable GFR greater than or equal to 30 for those who are undergoing dialysis or for patients especially who are at risk for heart failure. So use that 30 cutoff to think about who needs to get some fluids before or after you give them contrast, because they do mention that for time critical diagnoses in which the contrast enhanced scan is necessary before you have hours to hydrate these patients, that you should not withhold the contrast and you can consider giving it to them, giving them fluids after the fact to try to mitigate the risks of AKI, recognizing that there is no data to support this statement that they make. Next, how about for patients who are on dialysis already, but still have some residual kidney function? Do they require different treatment than do those patients who are on dialysis and don't make urine anymore? The short answer is yes. They recommend that for patients who are on dialysis who still make urine, you should treat them the same as patients who are not on dialysis and have a GFR less than 30, since the loss of residual kidney function may have some adverse quality of life and overall survival implications. So for non-anuric patients with residual kidney function who are on dialysis, you should really consider them similar to the patients who have a AKI or a GFR less than 30 but aren't on dialysis already with respect to the potential nephrotoxic risk of contrast media. They recognize, again, that there is not a good body of data to support this statement, but because of the theoretical risk, they do make that recommendation. Fourth, how about dialysis patients who get contrast? Do you need to alter their dialysis schedule? Do you need to admit them to the hospital to get an extra session of dialysis after getting contrast? The answer to this is unequivocally no. Patients can keep their standard dialysis schedule and do not require alteration to it after receiving contrast, regardless of whether or not they still make urine and are on chronic dialysis. Finally, should any of the above recommendations be altered in patients who are receiving other nephrotoxins, especially chemotherapy? And the short answer is no. But in patients with an AKI or with a GFR less than 30, they do say that it may be prudent to withhold some non-essential, potentially nephrotoxic medications for 24 to 48 hours after contrast exposure while monitoring renal function. This usually is not a decision that's going to come down to us, but for patients who are getting contrast and have significant nephrotoxic meds on their outpatient list that you're discharging from the hospital, it's worth having the conversation about whether or not that can be withheld for a day or two safely, but that's going to be determined on a case-by-case basis. So those are some of the specifics from the radiology and nephrology specialty societies, but this is like the biggest take home for us in the ED. The risk of contrast-induced acute kidney injury is lower than the dogma might suggest. And for patients with impaired baseline renal function who require contrast to diagnose their emergent condition, clinicians should not avoid giving contrast solely out of concern that it's going to cause an AKI. Specifically, they say, quote, patients with CKD stages 4 and 5 who have a relative rather than an absolute contraindication to contrast, and if contrast is required for a life-threatening diagnosis, which is pretty much everything we do in the emergency department for the most part, then it should not be withheld based on kidney function. So we are hopeful that, you know, the dissemination of this consensus will help to standardize practice among radiologists and nephrologists and us in the emergency department and any other specialties where contrast is part of their daily practice for patients, regardless of whether or not they have baseline pre-existing impaired renal dysfunction. So we're at time. This final QR code here will take you to a downloadable Google Doc that has the 15 recommendations from the consensus statement listed out for you. So you can consider bringing those back to your ED if you want to work with your radiologist and nephrologist to update any processes that might be in conflict with those recommendations from their own specialty society. So I'll leave that up for just a second, and then we'll show you our references with the consensus statements in both journals highlighted. Thank you very much for coming. And we ran over by a minute, but we're happy to stick around for a little bit to answer any questions that you may have. All right. No questions.
Thank you, guys.
Thank you very much. Appreciate it.
Thank
Have
you.
a great day.
Thank you.
Thanks, Shal.